All right, so today's a really big day because what we're going to talk about is how do you determine what to do for cancer treatment? One of the mistakes I see people make all the time is they first hear they have cancer and then they're saying, oh my gosh, I got to treat this right away. I got to kill the cancer cells. And at a superficial level makes sense. You want to get rid of something that's in your body that could be harming you. But the mistake so many people make is they rush into treatment very quickly without first determining all the different things that make their cancer unique. And what I'll hear sometimes is people say, oh, I have a very rare cancer. So what they were told is that their type of cancer is not common. And so because it's not common, there's not like a off-the-shelf treatment plan. And the thing that you need to be aware of is that every single human being alive on planet Earth right now is so unique. They are the only person like themselves in the history of planet Earth. So anyone listening to this, you're not just like one out of maybe 8 billion, you're one out of maybe 100 billion. So there's no data, there's no like pattern on, how many times someone exactly like you has been before. So when these different, let's say doctors or different labs or different medical professionals are saying, here's what you should do, there's no way they could possibly know if what they're recommending will benefit you unless there's extensive testing done first. Now, there are random cases like someone does something and they get better. Sure. There are people that have done hot tubs and saunas and, the cancer was fragile enough, it worked. But those people are outliers. Those are not the norms. What the overall data shows is that the majority of people that get cancer are probably going to die. Most of the people are going to die not because there was no treatment that would be effective for their cancer. They're going to die from cancer simply because they were reading stuff online and actually thought they could take some information offline and implement it, and that would result in killing all their cancer. So what I'm going to walk you through today is basically why testing is important, and then how do you use that information to determine what to do. So the first thing I'm going to bring up is this is something called the Pathways in Cancer. It's the KEGG database. And so if you take a look at the slide right now, it's a little big. I'm going to just make this a smidgen smaller so you can just see it's basically supposed to represent like a cell. So this dark gray border is the membrane of the cell, and there's like a dotted line border here, and that's supposed to represent the membrane of the nucleus. So all these genes are supposed to be inside of the nucleus in theory. And then basically what happens is there could be a given pathway where there's some damage or dysfunction, and that can ultimately lead to cancer. So think about any type of cancer. Doesn't matter if it's breast cancer, leukemia, colon cancer, etc. What you usually hear is, I have, this type of cancer, and here's the treatments that someone is recommending. And those treatments may be like a standard of care approach with chemotherapy, or it might be an alternative approach with vitamin C. And what you really want to know is, okay, will that therapy be effective against the genes that are driving my cancer? And so if you don't know what these genes are, then you run the risk that maybe you're doing something that simply won't work from day one. And now you've wasted time and money doing something that wasn't going to work. It doesn't matter how much or how little or how fast or how slow of the therapy, it's just simply not going to work. So an example would be if you have a problem with this pathway, you don't get credit by targeting a different pathway. It's kind of like, think of it, it's like having a flat tire on one end of the car, and the mechanic says, I'm going to fix this other tire that has no problem. There's no benefit to you as the owner of the car or to the car itself. And that's what we're basically talking about here, is rather than just trying random therapies and hoping they're working, let's just use some precision medicine and then develop what we call a more targeted approach. So some examples, going back to the same KEGG cancer pathway, here's a model for prostate cancer. And some of the oncogenes that you typically hear about is like the androgen receptor, and there's a couple of other gene fusions. But basically it outlines like sort of like the dominoes, if you will, that interact with one another that lead to oncogenesis or cancer forming in the prostate. And so kind of knowing which genes are involved in someone's prostate cancer, that allows the appropriate doctors to have appropriate weapons or therapies or treatments that target those pathways. And then here's another example. These were just sample cancers I pulled off from McKay Cancer Pathway site. This one's bladder cancer, and similar thing, it identifies the primary oncogenes, and it shows you the process by which these pathways lead to bladder cancer. Now, a lot of times people say, well, why do I have to do all this stuff up front? Well, the rationale for doing this up front is first, just from empirical observation, most treatments fail. And so you'd say, well, if so many treatments fail, what's the logic of rushing into treatment? That's kind of like saying I'm going to rush to fail. If we take a look, why do treatments fail? That gives us some really good insight that pulls us back to why we should do some thorough testing first. So I want to show you, this is from Sloan Kettering. So Memorial Sloan Kettering published this webpage in 2014. So this is dated information. But it talks about a concept called tumor heterogeneity. And basically what they did is they used a gumball machine to depict what we thought about tumors and cancer cells within the tumors versus the reality. And so in this model, the idea is that we thought a single tumor, as depicted here by a single gumball machine, we thought all the cells inside that tumor were the same. And then what we learned as science and better analytical methods progressed, we learned is that the individual cells are actually not the same, that there's some variances or differences. That's what they used here, is they used different colors like yellow, red, green, and blue to depict that these are not all the same cells. Now, in more recent data, we also know that inside of a tumor, it's not just cancer cells. There could be fibroblasts. There could be lymphocytes. So think of it, human cells, but they're not cancerous. There could also be bacteria, viruses, and other types of organisms. So that's referred to as the intratumoral microbiome. And also what could be inside that tumor are chemicals from the environment that cause cancer. So the point being is this. Let's say you had a balloon and you fill up that balloon with water or you fill it up with air. It doesn't matter if it's a gas or liquid. The balloon expands. And now you let that material, whether it's gas or liquid, out of the balloon. It's dramatically smaller, but the balloon is still there. Like the balloon didn't disappear. So even though the balloon is smaller, quite a bit, you might think, okay, like there was a big change, right? Because in the mass of it. Well, think if that was cancer and you had all this non-cancer material in a tumor. As that non-cancer material disappears, and now you have this remnants of the tumor. Think of it, that balloon that's deflated. Well, that doesn't mean the cancer's gone. You may actually have the exact amount of cancer that you started with. And that is something that's never really discussed with patients. Like doctors don't say, hey, there could still be cancer there. They simply say things like, oh, nothing showed up on the scan or on the imaging. So this kind of information is getting well known now. We now know there's a lot more variables that determine what shows up on the scans, and that we need more precise details than just an MRI or a PET scan, ultrasound, or a CT. And one of the other reasons why this tumor heterogeneity concept is so critically important, this is a major review paper from 2017, and it points to that tumor heterogeneity can lead to resistance to different cancer therapies. There's a number of key points, but the main one is sort of second bullet point here. Tumors with high levels of intratumoral heterogeneity might predispose patients to inferior clinical outcomes. So basically what this is saying is, if I go back to the Memorial Sloan Kettering page, the greater the number of colors, like the differences in these intratumoral cells, let's say when there's a biopsy done and due to no fault of the surgeon, they grab, let's say, yellow. So if they sample here, here, and here, they got yellow data at all those 3 time points. And it kind of, the idea would be that these yellow gumballs would have different genes in them. And so they wouldn't know about the red, the green, and the blue. And so now when a treatment plan is developed, really nothing is known about red, green, and blue. So there couldn't really be treatments for that. And so as you treat this initially, maybe you kill all the yellow cancer cells, let's say, but the red, green, and blue, they're still there, and now they pick up signals that later on lead to them becoming resistant to other therapies. So what I'm basically talking about is we want to try to know as much detail about these different cells or different gumballs in a tumor so that we could plan accordingly and make sure we have the right combination of weapons. Because in general, single therapies or monotherapies tend not to work the majority of the time. What I see over and over again at our clinic in Scottsdale is people that have done standard of care approaches and failed, or people that did alternative medicine approaches and failed. And then when you say, well, what was done? And it would just be something like, well, one drug, or they did one type of IV, like an alternative set like vitamin C only. And you say, well, did any of your doctors take the time to look at the genetic details from your cancer? And most of the time, what I hear is the patient doesn't even know what that is, which indicates that their physician in charge of their care never took the time to communicate to them like what details make their cancer unique and what the strategy or plan would be. They simply gave them a treatment plan, and the patient doesn't know enough that, well, this doesn't really pertain to me as a unique human being. This is just for a generic label. So like breast cancer, here's a treatment. So one caution I always tell people, if you walk through the door and before they know your name, any medical center has a treatment plan for you, you got to know, okay, they're not treating you, they're treating the label. And that's important because those strategies typically don't work. So one of the things I often hear about is people would say, well, what about immunotherapy? And what I like to do is kind of insert here this sort of little detail that this is from Johns Hopkins Medicine. So this is from their own web pages and talks about immunotherapy. Now it says precision medicine in action. Notice that right in the title of this webpage. As you scroll down, it's got some really nice stats, but the main point here is that immunotherapy works in 15 to 20% of the patients. That's a positive way of looking at it. But another way of looking at it is 80 to 85% of the time it fails. So the question would be, how could anyone consider an 85% failure rate a good thing? Like what that means is most of the time it's not going to work. Well, people aren't told that. What people are usually told, oh, you have this marker and a test will work. The treatment will work. And then when it doesn't work, they're not told, well, how come it didn't work if you told me, how come it's not working now when you told me earlier that it would work? And I'm going to show you now is like, why is it this way? So first, let's take a look. This is a sample report. This lab is called Tempus, and is one of the labs that we use here. When we do Tempus testing on someone, first, we simply do everything possible. And what I mean by that, Tempus has some really wonderful algorithms. They guide the different medical professionals involved in someone's care. You put in a type of cancer and it tells you all the tests that should be run to really get a good understanding of what is going on inside of this cancer. And in the reports, they tell you like somatic mutations. So this means this is a gene mutation that's in the cancer. It's not something this person was born with. And then this mutation, when it's black with white characters, this is supposed to represent like a capsule. This color coding system here, this indicates that there is an FDA-approved therapy for this mutation, for this type of cancer. Then it tells you other genes that are potentially important, but there's no FDA-approved treatment for this particular condition and this gene. So that's also important because if you don't know, like this other stuff is going on, that could impact you later. So now kind of think of it this way. You have 1, 2, 3, 4, 5, 6, 7 genetic mutations. So think of that almost like 7 pathways that could potentially be driving this cancer. And a doctor comes back and says, I'm going to treat 1. You would logically ask, hey, doctor, what about the other 6? Well, most people never see these reports. So the patients don't know there's 7 things going on. They only get told 1. And so from that, you then see why so many times treatments fail. They're not even addressing all the different pathways. Now, if we go further down, the lab will tell you like, hey, there was nothing you were born with that could be driving this cancer. And then it talks about immunotherapy markers. Like it tells you, hey, immunotherapy in this case won't work. So there'd be no reason to do it. Like if you're not seeing any data that could make it appear like it'd be useful. And then over here, you see this is the medication that the FDA approved for the genetic mutation. But if you go down further, page 2 tells you, yeah, the FDA approved therapy. According to the NCCN guidelines, ultimately it doesn't work. So it's an unfavorable prognosis. So here's what I'm saying. That if you went to many centers that follow a standard of care approach and they do the testing, they're going to say, oh, you have CRAS. Oh, here's the approved treatment. And they're going to do that treatment. And in the end, the treatment will still fail. So this is modern medicine now. This is not like outdated. This is stuff that most centers are following this approach right now. So now when people say, well, I thought it was going to work, how come it failed? It's simply because the doctors never gave them the full report. So they're not seeing like page 2 of the report. That's why I always tell patients, any tests that you ever have done, make sure you get a copy of the results. Every center now should have a patient portal that you could log in and download PDFs for. Like it's pretty standard. Any places that don't have that, at least make sure you get the hard copies and then convert it. Like you could scan and make your own PDF so you have copies of all your records. These reports also tell you clinical trials that may be useful. Most of the time, I don't recommend people go into clinical trials because what I've seen is that they're overly restrictive. There's no guarantee that anything's going to benefit you. And in the end, it could be addressing only one component of someone's cancer, meaning we know it won't work. So think of it this way. Here, this study is looking at the CRAS mutation only. So if you went in there, you might say logically, well, what about the rest of the mutations? How is that study going to help me if I got all this junk going on and it's only addressing one? Now, further down, look at all these other genes that are driving that could potentially be involved, I should say, in this cancer that are completely ignored. So you start to get the impression that, wait a minute, if there's all this stuff going on, how come I'm being told to do vitamin C only, right? How come I'm being told to do one medication only? And that's because the FDA has to approve the claim of a given treatment, working for a particular condition or gene and the condition or some combination of the two. And so when the FDA hasn't approved it, the labs then don't have the ability to put in the data that substantiates that as a treatment. So it could be stuff that works. So let's think about exercise and nutrition. Let's think about, getting good quality sleep. Those have a lot of health benefits. But those would be claims, and the FDA isn't going to approve that simply because who's going to fund it? So who's going to fund a study that says, hey, sleep will help fight cancer? That's the problem we run in with some of these kind of current situations we're involved in. So now as I kind of say, okay, well, we're still talking about like how to know what treatments to do. And we first focus on, testing the cancer, because testing the cancer gives you specific weapons that could provide a targeted approach to cancer in someone's body. The next thing would be look at, what are 3 areas that are critical to fight cancer? One area is nutrition. Now I hear people all the time say, I take vitamin D3 or I take this other nutrient. And they take it and actually believe that it will help them. And so if we just did like a thorough review of all the research to date, we see that there's a number of, let's say, nutrient deficiencies that are linked to an increased cancer risk. So number 1 is iron. Number 2, vitamin D. Number 3, selenium. Number 4, folate or vitamin B9. Number 5, vitamin A or retinol. Number 6, phosphorus. So these nutrients are really important. If they're too low, you can increase the risk of cancer. So now well, how do we know then what you should take? Because you don't get benefit of taking vitamin E if you already have adequate stores of vitamin E. Well, it gets back to we test you. So we actually do a blood test, and in the blood test, I would measure, this is a sample report I downloaded from a lab website. I would measure the cellular levels of the different nutrients and also the serum levels. So think of the serum tells me what's outside the cell. That takes into account factors like intake, digestion, and absorption. And then I measure cellular because that tells me what got inside the cell, and that measures utilization. Between all these different areas of digestive physiology or nutritional health, the most important is utilization. If you don't get a nutrient into the cell, you don't get the benefits of that nutrient. And so this is super critical. And this is an area that is almost always ignored. I can't tell you how many people come in and say, oh, I'm taking vitamin C and I do vitamin C IVs. And then when we test them, they're vitamin C deficient. And the reason is when they were doing a vitamin C IV, they had the infusion rate too high. So it raised their blood levels so high so quickly, it turns on transporters in the kidney that basically filter vitamin C out of the blood faster. So kind of think of it, when it's too fast in, it activates mechanisms that the body could quickly excrete it in the urine. So now all that vitamin C coming in doesn't really do the benefit you're expecting. It just leaves the body in the urine. And so the reason why we want to get tested, because you could quickly identify what nutrients are low and make sure you get those nutrients into your cells. And the cells that we test, by the way, for this test, we test lymphocytes and neutrophils. And lymphocytes are important because they represent a main branch of the immune system that fights cancer. And the neutrophils are important because they represent a main branch of the body that repairs damage. Now, lymphocytes and neutrophils do other things. I'm being a bit overly simplistic there, but it's important to know that at least we're testing cells of the immune system, because if they're low, well, your immune system is not going to do the best job possible. And that addresses like a concern, like anyone that has cancer. You might say, how come my immune system didn't do its job of fighting, and killing the cancer cells? Well, you can't expect an immune cell to do the best job possible when it's missing nutrients that are essential for cellular function. So what I'm showing you so far is very logical, straightforward approaches to fighting cancer that are reproducible. So it doesn't matter what country someone comes from. It doesn't matter their age or ethnicity. These principles still hold true. Next, what I want to talk about is another area that makes significant impact on either causing cancer, or do treatments work, or if the cancer spreads faster. And that's environmental chemicals. Now, environmental chemicals really include categories like mycotoxins. So this is naturally occurring chemicals from mold. It includes environmental toxins, that say chemicals made by humans and dumped in the environment. And then it includes things like PFAS compounds, which are also made by humans and dumped in the environment, but it's like a whole separate category. Sometimes you hear them labeled as forever chemicals. And then we also have heavy metals. So these could be from natural sources or non-natural sources. And as we kind of look at the laundry list of potential chemicals and the different cancers that they're linked to, essentially what it comes down to is anyone that has any one or more of these chemicals in their body is at risk for DNA damage, which then makes them at risk for cancer. Well, we could test the body for these different chemicals. We can identify their values. And then the lab will tell you literally like what these chemicals can do. So as we go through, I'm going to scroll to a part of the report where it shows something that's more pertinent to talking about cancer. So here's arsenic. This was moderately elevated on this sample report, and the lab will tell you that severe health implications, including skin, bladder, and lung cancer. So when there's very strong relationships with certain substances from the environment and cancer, the labs will tell you this. And let me show you one other area here. So this is triclosan. This is an antibacterial and antifungal that's in a lot of different products, including toothpaste, soaps, and detergents. And when this substance gets into people's bodies, it could damage their kidneys, it could damage their liver, can damage their lining to their digestive tract, and impair thyroid function. And I mention this because a lot of times, you don't just get exposure to a substance once and then get cancer the next day. It takes decades. And one of the more complicated parts of this process is that, let's just say that you have one chemical affecting liver function. Now, your liver does not detoxify the body as well as it could. That leads to a domino effect that other chemicals start to build up in the body. So as all these chemicals are building up in the body, now you have a total toxin burden that's increasing with time. That leads to more genomic instability or DNA damage, and it starts to exceed the body's ability to repair that damage, which then leads to cancer. And then what happens later, I'll show you, if this is not addressed, it can render different treatments ineffective. So if we go back to like the testing I was showing you earlier, so like let's say you have a genetic test report from a lab like Tempus or some other labs like Menarini or Billion to One, and it tells you like these are the genes that were discovered either in a tumor sample or in the blood. At least doctors have a chance to pick a treatment that may target a given gene. But in this model, what these labs aren't considering, because they're testing the cancer cell or the tumor tissue directly, this type of process does not take into account the chemicals that someone can have in their body that could be interfering with these, like here's glyphosate here. These chemicals can interfere with a treatment from reaching the target on the cancer cell. And just to kind of show you, like, see it says environmental chemicals, breast cancer progression, and drug resistance. This is a major review paper, and it uses breast cancer as the model for all cancer because breast cancer and prostate cancer are some of the more common cancers. And so using them as models to apply to other types of cancers that may not be as common helps different doctors to think about different approaches. And so the point is that even when you're working with a medical professional, and the medical professional, let's say, tests your cancer and says, oh, we found something that, here that we could target that will help you beat the cancer. So example, like when you hear breast cancer, you usually hear about tests like the estrogen receptor, like ER positive, or progesterone receptor, PR positive, or HER2. And what is not seen in those genetic tests is that, well, there is actually chemicals also in the body that could prevent the drugs or the treatments from getting to those cells. So someone could be doing the appropriate treatment on paper and it may still be ineffective. And so then this, by the way, is all public domain. Everything I'm showing you, there was no username or password for. So every doctor, doesn't matter their discipline, doesn't matter their education, they could find this stuff if they have an internet connection and a computer of some kind or a cell phone. So we covered now basically several areas. We have one more area to cover. And again, this is all needs to be done before starting treatment in an ideal way. And the next area we look at is organisms that can cause cancer. So right now there's quite a bit of data on different viruses that can cause cancer. So HPV, hepatitis B, hepatitis C, Epstein-Barr, and the list goes on and on. And if in other areas we know like certain bacteria like H. pylori is linked to esophageal and stomach cancer. There's also, what's not shown in this list here, is Fusobacterium nucleatum. That's an oral organism that's now been shown to it's been linked to colorectal carcinoma or colon cancer. And we've actually tested different patients with pancreatic cancer and other cancers, and we find that same organism present. So the way that we're testing, I can't prove causation, but what I can tell you is this. If we treat the organism, and we consider these organisms infections, if we treat them with pretty simple antibiotics, we see dramatic improvements. We see like tumors shrinking. We see people getting their strength back right away. And the reason why I mention this is that they're very inexpensive, they're very simple to introduce, and they're very short in duration. In some cases, 3 days, in other cases, maybe 30 days. But in 3 to 30 days, to have a dramatic impact on someone's health by eliminating what we consider an unknown infection, that's significant. It's a lot less toxic than many of the drugs and other therapies that are currently being promoted right now. And then we also have different parasites. So as an example, schistosoma is known to be linked to bladder cancer. So you would expect any man or woman with bladder cancer that doctors are testing the urine and the blood and biopsy samples from the cancer for schistosoma. And what I usually see most of the time is completely ignored. None of these tests are done. And so one of the ways that we could do it here, we could do a stool test where we could look at all kinds of different organisms. We also have, if the tumor that someone has in their body is fairly superficial, something like a breast lesion or like a skin lesion, we could take a sterile swab and we could swab that tumor or the lesion, I should say, and then we could actually send that to a lab. We can measure the DNA from over 57,000 different organisms, and we could tell you if there's bacteria present that may impact the rate of growth of that cancer or make the cancer resistant to treatment. We also do a sputum or let's say upper GI, upper respiratory sample. We have the ability to have sterile swabs and test the sinus cavity, test the back of the throat for different organisms. We have someone cough up something and basically cough up the saliva or mucus into a sterile cup and test that for organisms. And then we also do, in men, we do the urine and first morning urine, and we do a semen analysis for different bacteria. And in women, we do urine and vaginal swab. And then basically we get all these bad guys from different areas, and we test it to see if there's anything there that shouldn't be there. In every single case, when I have a patient who was diagnosed with cancer, we have found all kinds of, pathogenic organisms. And I think this is one area that has been really missed big time by oncologists. I think that the methods that most oncologists are using right now are culture-based methods that are pretty outdated by the more modern analytical methods that are available. And it raises a question like, if the FDA is supposed to be ensuring like human safety in the United States, why are they allowing all these outdated methods to still be deployed? Instead, why not provide resources and funding so every hospital, every outpatient medical facility can actually provide the most robust testing methods so that people can get more accurate information more quickly and treat what's going on without having to resort to more expensive methods like chemotherapy. Just a different way of looking at it. And then the reason why the microbiome is so important, by the way, we know here's the role of the microbiome in the gut. This would be like the lower GI tract, I should say from the mouth to the lower GI tract. This is in breast cancer and drug resistance. So just like chemicals from the environment, organisms that are pathogenic or even organisms that are sometimes called commensal, when there's an imbalance in the body, it can create drug resistance. So now therapies that should be effective may not actually work. And then here's now, some other paper showing the same thing, that there's all these molecular mechanisms that have been discovered that, basically drives resistance. And most of this is driven by the microbiome and environmental toxins. So in summary, what I'm basically saying is, in order to know what you should do for treatment of the cancer in your body. You have to first know, okay, what are the details of my cancer? Those details are way beyond just saying like breast cancer or prostate cancer. It's way beyond just saying ER positive, PR positive, etc. If that's all you know, you don't really know much about your cancer. You're really in the dark, and you can't make a good decision for your life or your health if you're in the dark. Second thing to look at then is what micronutrients are low, because how would you know what supplements, if any, to take if you don't even know what you have in your body? The third thing to look at is the chemicals from the environment that are known to cause cancer, or maybe they're not known to cause cancer, but they damage you in another way, and that indirectly sets the stage where you're more inflamed, and that could lead to cancer later on. And lastly, the microbiome in multiple areas of your body. And so if you're going to any center and they're rushing the treatment without knowing those areas for testing, then you may be running in the wrong direction. And if you're going in the wrong direction, it doesn't matter how fast you run, you still won't get to where you want to go. So those are the four critical areas. Now, there's a lot more tests that could be done. There's a lot of other things. But in terms of like right away knowing what kinds of treatments to do, those are the more important areas. Now, in terms of actual treatments that have withstood the test of time, so some areas that you should think about. So oxygen or ozone, I'd kind of use those two synonymously right now. And then the other thing would be heat, and then also movement. If you're on a budget, let's say you go, I have limited funds, I'm not sure what to do, I can't afford testing, just exercise and move more. We literally have, I would say, depending on how we're categorizing people, as high as 50% of patients just doing exercise with oxygen, following the protocols we developed only at Cosenta. No other center in the world has done anywhere near the level of research that we have. I see lots of guys talking about just doing EWOT protocols online. All you got to do is ask them, can I see your data pre and post? And you find out they have no data. So how are they making a recommendation when they haven't measured anything? It's a logical question. We've developed protocols in-house that exercise alone helps almost half the people with different medical conditions treat their medical condition. I'm not saying it's going to help everyone solve their medical problem, but it gets you pretty darn close to the right direction. So you could do a lot of that stuff by contacting us, so we could work with you to create the right protocol and do that stuff from your own house. And if it works, you don't need anybody else. Even if it's not working, then okay, I need to do some more serious stuff. And then we have very specialized ways of delivering oxygen and ozone to the human body. We have more different approaches in-house than any center I've ever seen. And then we also have different ways of heating the body. We have a number of FDA-approved therapies, so we get pretty hot, and it's allowed. It's approved for the different conditions, but it does it safely. And that's important because I see a lot of times people come in and have weird burns from some center they went to. I'm like, well, how do you know that therapy was approved for treating the condition you have? And they never took the time to find out. So they were doing something that most likely was never going to work, but they were told by someone it would. So at Cosenta, we have actual data that we collect from patients in-house. We could show you. You could talk to actual people that are in-house, and they'll say, yeah, this is how I came in. I had all these issues, and look at me now. Like, all these issues are resolved. So we put you in touch not only with medical professionals, but also patients that could say, yeah, this stuff is really effective, plus it's fun. That's probably the single most important thing to think about the treatment process. It's one thing to say do something and it's painful and hard, so you got to do it because you got to go through this journey to get better. But it's a lot easier to do it when you're part of a community that's founded on positive energy and success, and also intelligence and science and competence based on experience. So I hope this video was helpful. Hopes it gets your mind thinking in a different direction than what most websites will have you think. Most websites have you think, I'm going to take one substance and somehow my cancer will be gone. That usually is not the way things work. And I hope after you read this or see this video, in whichever form it comes to you, that you give us a call and give us a chance to prove to you that we really do amazing things here at Causenta.